Good evening, I'm Maria Muro, and welcome back to our show. Head and neck cancer accounts for 5 to 10% of all cancers in the United States. Head and neck cancer is more common in people over the age of 50 and 3 times more common in men than in women. If detected early, head and neck cancer is often curable. Tonight I'm excited to have Dr. Paul Spring, a local head and neck surgeon who's here in our studio. Dr. Spring received his medical degree from Ohio State University, followed by his residency in otolaryngology at Tulane University with a fellowship at MD Anderson Cancer Center. He is board certified with the American Board of Otolaryngology. Thank you so much for being here, Dr. Spring.
Thanks a lot, Maria.
You know, always good to see you, and you know, you have a busy practice. You're a busy head and neck surgeon, so I'm always so thankful, you know, to have physicians like you take time in their evening to be on the show and to educate our viewers on important topics. Okay, and tonight the topic is head and neck cancer, everybody. But before we start on this topic, Dr. Spring, we'd like to learn a little bit more about you. Okay, so you're an ear, nose, and throat physician.
That's correct.
Okay, and then you also did a fellowship in head and neck surgery.
The year after I began my fellowship at MD Anderson in Houston, after I finished up at Tulane in my otolaryngology residency, that was in 98 to 2000, and then from there I went on to hold positions in different academic centers in doing primarily head and neck, a lot of clinical, some research, and so. That's
Wonderful.
Pretty much right, yeah.
And why did you choose this field of medicine, doctor?
Hard to say, I guess, because I just enjoyed it. I liked the people that were in it. The anatomy, everyone says that, but it is kind of cool. The neck is the roadway to the rest of the body. A lot of different problems arise there, not just cancer. It's got some, you know, systemic expression of systemic diseases that are interesting. I guess that's why I went into it.
Well, also with ear, nose, and throat, you're covering a lot, and head and neck.
Right.
You're covering a lot of ground,
right.
And obviously a lot of disorders. And so let's talk about the physicians you work with. I know you're in private practice,
yes.
So you do the ear, nose, and throat, sinus.
That is correct.
Okay, and when it comes to head and neck surgery or these disorders or cancers that come your way, you know, walk me through that process.
Well, depending on the person or persons that the patient's referred from, that has a lot to do with the way the patient's coming at you. They can come in just with a simple symptom like hoarseness, or they can come completely worked up and ready to operate when that's the case. For instance, somebody may come in with just a cough and perhaps a little bit of hoarseness. You perform a routine examination, which would include a scope that goes down the nose to look at the voice box, and all of a sudden there's a lesion there. Well, there you have it. Then you know you have to do something, take the patient more than likely back to the operating room to biopsy. In some patients, say thyroids, the patient's already been seen by an endocrinologist. The patient's had an ultrasound. After the ultrasound, there's a fine needle aspirate, which is a type of biopsy that goes into the tumor or the growth. That comes back and it looks suspicious. Then the patient is sent to you for surgery. So we obviously we're the endpoint for surgical issues in the head and neck area. But as you alluded to before, when it's a kind of a general referral, it can turn into something like that. It just has to be worked up a little bit more thoroughly.
Okay, and also you work with radiation oncologists in terms of the, you know, the full scope of the treatment. So if a person, you know, does have a certain type of head and neck cancer, and then you will come in to this, I guess, this team approach where you'll actually remove the tumor. Is that correct?
Yeah, you know, it's a very interesting point that you bring up. I mean, from the late 80s to early 90s to where we are now, head and neck cancer was almost always a surgical and radiation type of malady. What's happened is, as we've become more involved and have gotten a better understanding of chemotherapy, it's worked its way into the treatment regimen to the extent we have something called organ preservation, which means basically eliminating as best you can surgery, which isn't always a good thing, but can very well be, so that you have those two disciplines, radiation and chemotherapy, taking care of the head and neck surgeries. So when it comes to head and neck cancer, your main people that are involved, your radiation oncologist, medical oncologist, your surgical oncologist, which is the head and neck surgeon. But then you also have to realize these people have problems with swallowing. So you get speech pathology. Then you have dental oncology, because it's always involving the oral cavity, and the teeth are involved in that. And so and other forms of rehab are necessary after surgery or after treatment. So there's so many other groups that are involved in it.
Okay, and obviously, and later on in the show we'll talk about the it's a very traumatic type of cancer for some patients. I've met a few of them who've had some disfigurations occur, and I've met some of your patients from your practice, and some of them have just gone on to do really, really well.
Yes.
Have you seen a lot of advancements in this field in terms of again, I'm all about prevention, doctor,
Right.
and if you can prevent it, and we'll talk about ways you can prevent it, but then also early detection, is key. So let's talk about screening, okay? We've heard about it in the news, where they had a whole campaign around head and neck or oral screenings. Let's talk about that. Where do people go get these type of screenings?
Well, if you're looking for kind of a free or community screening, you have to just be aware. Around April, there's something called the Yul Brynner Society, and Yul Brynner was an actor well known and had head and neck cancer of the oral cavity. And so there's some medical centers across the country that have embraced the Yul Brynner screening when that time comes up. Around here in New Orleans, I'm not really aware that that's been really celebrated.
Well, when you go to a doctor, when you go to the dentist, I know my dentist will always, do, I guess we'll look in my mouth, not just look for cavities, but also look for any type of lesions. Is that, do you get, some, I guess, dental dentists who will actually refer out to you as well to take a look at something if it looks a little abnormal?
Dentists and oral surgeons are very active in the screening process.
Good.
I believe that it's come down as a mandate of some sort in the dental society and dental academy to have their dental hygienists looking for these. So these people will perform these examinations while they're prepping your teeth for examination by the dentist himself. And again, as you said, the oral surgeons, they too will be involved in some degree in the diagnosis and in some cases in the treatment of head and neck cancers, depending on where they are.
Okay, all right. Well, let's get started. I want to learn a lot about these head and neck cancers that that you're going to discuss with us. So, I just want everybody to know that if you do have a question, whether you know someone who's going through a head and neck cancer situation right now, or you just want to learn more, you want to ask Dr. Spring a question, feel free to call 866-3200. Thank you. All right, so doctor, I want to put up a diagram and just kind of walk us through the head and neck, head and neck region and what that really entails. So let's take a look.
Okay, here we're just talking anatomically. We're not going to refer necessarily to cancers. So the first tag you have up there is paranasal sinuses. So those are, quote, the sinuses. And about 5% of your head and neck cancers will occur there. They won't all be squamous cell carcinoma, which is the most common type of head and neck cancer, but what you're talking about is a generality head and neck cancer is about 4 to 5%. Okay. Then that includes also the nasal cavity as well. Then you have the area which has the most frequent number, or the largest number of head and neck cancers, and that would be the oral cavity. Oral cavity has a bunch of different subsites, things like the lips, the gums, they call the alveolus, the lining of the bone that sits on top of the mandible, and the maxilla. You have the tongue, which is kind of chopped up into two sections. One's the front part of the tongue, which is the front 2/3 of the part of the tongue that moves. You then have the floor mouth. You also have what's known as the buccal mucosa, and then you have the hard palate. So these are all subsegments of the oral cavity, most common area for head and neck cancer, particularly in countries like India, where they use this thing called pan type of tobacco, where they're always using it, reverse smoking, these kinds of concepts that they actually do, that they practice. Then you have the larynx, and there are quite a few cancers done there, not to mention the oral pharynx.
Okay,
Yes.
and so now when it comes to, let's talk about the different regions, and again, I want to talk about the symptoms to look for, and then of course, the treatment options for it. So let's talk about the thyroid.
Okay.
The reason, the first thing I bring up with thyroid is I have a brother-in-law of mine who was diagnosed with thyroid cancer, and of course, when you hear cancer, everybody freaks out, and you think, oh my God, this is horrible, but he did exceptionally well. They removed, I think for him it was a partial thyroidectomy. Could that be? Can you talk to me about that?
It's possible.
I don't recall. It was a while
likely,
ago,
but it is
you would
very
know
possible.
better. Okay.
And I'll tell you why.
Sure.
First of all, you mentioned thyroid cancer. Everybody's hearing a lot about it. I think what's happening basically is because of the forms of routine screening or screening for problems in the neck, such as ultrasound in the carotid areas, and the emergence of ultrasound as a diagnostic tool. we're seeing that thyroids are being looked at more critically. Well, thyroid nodules are extremely common. 50% of the population, 50 or in their 5th decade of life, will have that. 6th decade of life, 60% will have a nodule. So you can see as you age, the occurrence of a nodule is going to be much, much greater. That said, your thyroid cancers in general, which are female predominant, unlike the other head and neck cancers that you sort of alluded to, they tend to occur at a younger age. And so when they do, in general, their prognosis is quite good. There's a stage at which the patient doesn't do as well, where the prognostic factors work against them, and that's about 55 in women, 45 in men. But as I said, as far as your brother-in-law, was it?
Yes.
The only way he probably would have gotten a partial thyroidectomy is if the cancer found within his thyroid lobe or lobectomy, that's partial, was less than 1 centimeter, and there were no other nodules seen in the other side. They may have passed on that. He would not have received radiation therapy, and so he may just be under some sort of surveillance that everyone's comfortable with.
Right. And so have you seen more thyroid cancer in the past, let's say 10 years? And why is it? Why does someone develop thyroid cancer and someone else doesn't?
Other than something like Chernobyl, obviously, where we've got an exposure to a young population to radioactivity. As I said, it's just from a diagnostic standpoint. You talked about screening, you talked about early detection. Well, that's essentially what's happening. These people who have nodules that would otherwise go unnoticed, undetected, because we have these modalities of looking at them, they're picking them up more quickly. If they reach a certain size, which is roughly 1 centimeter, they will immediately get a needle put in there, or should have a needle put in there, and then you can aspirate cells. And if you find a cancer, something suspicious, then of course you're going to increase the number of patients that you have with that diagnosis.
And what symptoms typically would someone with thyroid cancer experience?
Unfortunately, very few, or fortunately, depending on how you look at it. It's simply a nodule. Most of your thyroid cancers, as I said, are kind of a low virulence. Patients do very well. There are factors and things you can look at. The most common type of cancer is a papillary or a follicular. They make about 80% of your thyroid cancers, maybe even 90%, and have a very good prognosis. The more malignant ones, your medullary and your anaplastic, far less common. And so people tend to do better, but that isn't to, people say, "Oh, I've got a good cancer. Thyroid's a good cancer." No cancer's good, and thyroids can really turn very nasty. So each case is individual, but if you're generalizing, then certainly thyroid cancer. Unfortunately, as I said, there aren't a lot of symptoms. I mean, people think of immediately hoarseness. To get hoarseness with thyroid cancer, you have to talk about invasion, either the trachea, the larynx, the nerve itself that controls the larynx. So.
Okay, well, let's go on to the next one. A lot of great information, doctor, so far. Oral cavity. So, all of us, I know, I floss, and sometimes I get canker sores, and I'm always just paranoid. Oh my God, what is this little lesion? So let's talk about what to look for with oral cancer, and any type of symptoms that someone would experience.
Unlike thyroid cancer, where I said is relatively asymptomatic, oral cancer is very symptomatic.
Okay.
And that comes very often in the form of ulceration. Whenever that initial layer of the mucosa, or the lining of the mouth, the tongue, is violated, there is pain. And so it can be an aphthous ulcer, it can be a premalignant lesion, but in some way that superficial layer is irritated, is angered, and that brings about pain or some something's wrong, and that then gets your attention. Okay,
we have a caller for you, doctor. We have Anna on the line. Good evening. How are you? Do we have Anna?
I'm doing okay. Thanks.
Hi, Anna. What is your question for Dr. Spring?
I have acid. Okay, yes. I have acid reflux behind my vocal cords. My question is, can that turn into cancer?
I guess the simple answer is yes, it can. And you actually bring up a very, very interesting point. We've seen this for the last 30 years, where reflux, as you're talking about, is any kind of irritant to the mucosal lining, and certainly acid from acid reflux would be considered an irritant, has the potential to cause disruption, and if you want initiate the premalignant process on any of the structures, especially in the in the voice box. And the back side of the voice box is called the arytenoid area. That's very frequently where we see irritation, but fortunately not so often cancer. Where we are seeing cancer, or where it's been described in the literature, is on the vocal cords. Now, the acid has to then get in, or the irritation has to somehow affect the vocal cords directly. And so there's some studies that say that there is a risk, a higher risk with reflux. It's a rampant disease, as we all know. So I think you're wise to take your medicines for it. I would say to you, though, however, the main issue with recognizing that you need something for your reflux is not so much for the upper aerodigestive tract, but for the lower aerodigestive tract, that area between the junction of the lower esophagus and upper stomach.
That was a really great question. Thank you so much. We have another caller. We have Kelly. Good evening. You have a question for Dr. Spring?
Good evening. My name is Kelly. How you doing, sir and ma'am?
Good.
Doing well, thanks.
Thank you. I have a question for you. My brother, he had a little throat cancer, and thank God he's okay now with radiation and stuff, but he still gets a dry throat and stuff like that. And when I went to the cardiologist, we had blood pressure high blood pressure that ran in the family. And I just wanted to know, they always check in the neck. What is that artery that runs in your neck? They want to check first when you go into the hospital.
I assume the only main artery is called the carotid artery. There's the vertebral arteries, which are branches off similar main arteries, but the main one's the carotid.
Okay, sir. Oh, thank you so much. Okay, so I guess that was an interesting question too, as to what do when you do go get a routine physical exam, what do they look for when they're examining, I guess, the outside of your throat?
The reason you would look at the neck in somebody with this suspect head and neck cancer would be looking for what we call local regional spread or metastasis. So all up and along the jugular vein, which runs parallel to the carotid artery on the left side and on the right side, are lymph nodes, about 75 to 100 lymph nodes on each side of the neck. And those tend to be the areas that, depending on where your head and neck cancer is, those specific echelons are where your lymph nodes will become positive if they're predisposed to doing so.
Okay, so if you feel like, a lot of times you're sick, you're not feeling well, and you feel like you have swollen glands, I guess is that
right.
something to look out for or to monitor?
Right. If you're 20 or even 30 in that age range, that's likely more of an inflammatory or infectious origin. But you're certainly right. Anything 35 and above, any neck mass in your neck should not really be there, and you should have it checked out, whether it's head and neck cancer or thyroid cancer, a thyroid benignity, something that's just something that needs to be addressed.
Sure. Okay, doctor, I want to continue with oral cavity and the oral cancers. Okay, I know a lot of people who still smoke, and here in Louisiana, 33% of our population still smokes, and that's a big problem.
Yes.
So people are smoking cigarettes, but also you see people who dip. Let's talk about that, the effects of tobacco use and head and neck cancers.
Well, I'm going to talk specifically because the data are there for smoking tobacco, not so much smokeless. The argument for smokeless tobacco will go on and on until there's some really well described studies, but there aren't nearly as many people who do that. So as far as smoking, yes, it increases your relative risk of oropharyngeal cancer by 33-fold. With the addition of alcohol, you add about 16-fold. So together, the multiplicity of that is 40, 50-fold greater risk of head and neck cancer in the oral pharynx because you smoke and drink. And as you said, that is the most common cause of head and neck cancer. But as you and I spoke about earlier, there's something called HPV, which is human papillomavirus, very, very much like the cervix cancer virus. And so we're seeing this affects a younger set of patients. So you kind of throw out the thing about, oh yeah, the guy's got to be a 60-year-old smoker to get it. You're looking at late 20s and 30-year-olds who, with oropharyngeal carcinoma, have it as human papilloma as the reason.
I want to continue that topic after we take this call. We have Tanya on the line. Good evening. How are you?
Good evening. How are you doing?
Excellent. Thank you for calling. What's your question for Dr. Spring?
I have a relative that's struggling with stage 4 cancer, and I would like to know what do you recommend so far as medication, food, or treatment at this time.
Okay, Tanya, can you just repeat that question? Because we lost you a little bit. If you can repeat the question.
It's cancer of the throat. I have a relative that's struggling with stage 4 cancer of the throat, and I would like to know what the doctor recommends.
Okay. Obviously, I probably have to know just a little bit more, and that would be specifically the location, if the relative has received any other therapy leading up to this. But in general, you're talking about stage 4, which by definition means advanced. Any kind of staging system, or the one in the head and neck, is a 1, 2, 3, 4. The first 2 stages are considered early. The latter 2, 3, and 4 considered late. When you're dealing with a late stage cancer in the head and neck, you're dealing with something that's going to be treated with multimodality therapy. That means that radiation alone is likely not going to get it. Chemotherapy alone certainly will not get it. And surgery alone may or may not get it. So you're looking at some combination of 2 or 3 of those modalities. So that's certainly what the individual is looking at.
Okay, thank you for that call. And we wish your family member, good luck and keep fighting. That's all
Definitely.
we can say. It's
No
always
question.
a good fight. Okay, so doctor, I want to continue with the HPV virus that you were talking about and how it leads to cancer. So you're seeing some 20-year-olds coming to your practice who are developing cancer.
Late 20s.
Late
yes,
20s. Okay.
These are oropharyngeal. They're starting to move into to look at base of tongue, which is oral pharynx, but they're starting to look into the oral tongue area to see if there's a correlation. But right now, the only established area for HPV-related carcinomas is the oral pharynx. So that includes your base of tongue, your soft palate, your posterior pharyngeal wall, and most importantly, or most commonly, your tonsils.
Okay, so when a young woman or a young man gets the HPV vaccine, will that prevent HPV cancer in the future in any of the head and neck areas?
There's some, you're talking about for the cervical,
Sure,
the Gardasil.
sure, yes.
That is being given. The subtypes aren't exactly the same.
Okay.
The more common ones are 18 and 16 in the head and neck area. I know they're also important in the cervix. I think the data are still out. Obviously, they're inoculating women, so it's got that subset. I think we're going to have to see longer-term results to determine whether that's going to be effective.
Okay.
But they have started bringing that up to also inoculate boys,
Right.
With the similar type of
Yeah, I've been reading about
vaccine.
that. So, and I think that
So I don't know. I really don't know.
it's a hot topic
I don't
right
think
now.
it's a bad idea, quite frankly,
Okay.
if there's quite a bit of safety associated with the vaccine itself.
Okay, I guess we'll wait and see, right?
Yeah.
And that's the amazing thing with medicine is there's there's always research. Physicians like you who are at the forefront of always finding whether it's cures or really giving people a greater quality of life even after a diagnosis. The show goes by really quick, doctor. We only have about 8-9 minutes left, so let's wrap up by talking about again. So we talked about the oral cancer. We talked about the larynx. What are the more common? Any other common? Is it the throat cancer that you deal with?
Specifically in the throat, I mean, we touched on the major ones.
Right.
The oral cavity, the larynx, we mentioned to some degree. The larynx just isn't, I mean, it's called the voice box, but the absolute function of the larynx is solely for breathing. Speaking is way down the line in terms of importance, but that's how we recognize it.
Okay.
We recognize it when it's involved specifically with the voice box, with the true vocal cords.
Okay.
Above the true vocal cords is what we call the supraglottis, or above the true vocal cord anatomy, and that would be the false vocal cords, the arytenoids. These structures help prevent things from getting into the airway and into the lungs. And then you have a smaller area which accounts for about 5% of all laryngeal carcinomas, and that's the subglottis.
Okay.
That's the area just below the true vocal cords. So just for instance, if you were to have a cancer in your supraglottis, which is the upper portion of the larynx, you may go a long time without seeing symptoms.
Okay.
You may not notice an ulcerated lesion causing you too much trouble. Maybe a little sore throat, a nagging sore throat.
Sure.
Maybe a little bit of a cough. Rarely, unless they get decently enlarged, we have some real troubles with swallowing. Whereas, as we've already said, with a lesion sitting on the vocal cord itself, especially on the contact surface, you're going to notice a problem immediately.
Okay.
Now, if you want to extend beyond just the oral cavity and the
I'm going to stop you right there, doctor,
madam.
because we have a very patient caller who wants to ask a question. We have Harry on the line. How are you, Harry?
Yes, thank you. I was diagnosed with, actually what I have is a pain in the neck. Not trying to be funny, but it was diagnosed as arthritis. And he said the only way to handle it would be to kill the nerves in the spine. Have you ever heard of such a thing as this, doctor?
It's Harry. It's out of my bailiwick. I'm not that familiar with treatment for that kind of problem. You're talking about arthritis and pain in the neck. What we do and what we engage in is primarily soft tissues, anything in front of the spine in the head and neck area. So unfortunately, I can't give you an educated opinion on that, but sounds logical.
Okay, thank you. Thank you for that call, Harry, anyway. I hope you find the help you need. All right, so doctor, to wrap it up, I want to talk about the, I guess the post-operative care for these type of patients. I know that a lot of them, we talked about Siskel and Ebert, who had, part of his, was it his jaw?
Roger Ebert, yes,
Roger
that's correct.
Ebert,
Yeah.
yes, sorry, I screwed up his name. But anyway, and a lot of them will have, some disfiguration. How do you work with these patients? After they were diagnosed, they've gotten the treatment options, they went to see you, they get the surgery, and then they're still left for the rest of their life with a very visible
no question
disfiguration.
We didn't really talk about it, but he had a salivary gland tumor. And he also had a number of recurrences. That means the tumor came back in the same spot and in the neck in his particular case. And he had to go re-resection because for that particular tumor, surgery is really the only modality of therapy that works. I mean, you can add radiation therapy, it certainly contributes, but surgery is what he's got. So they kept whittling away. He kept losing parts of his jawbone. And I'm not certain what his specific reconstruction options were because you don't really typically reconstruct in a bed where the tumor's active. Does that make sense?
Yes.
You want to know it's clear,
Sure.
and then you can start putting in things. So I don't know the specifics in his particular case, but you're exactly right. We bring in people called plastic and reconstructive surgeons.
Sure.
They may be ENTs to begin with. In general, they started out as general surgeons or just went immediately into plastic surgery, which they're able to do now. And we rely on them heavily because when you're talking to a patient and you're telling them you're going to remove their larynx, although there isn't so much reconstruction, we're talking about losing their jaw or losing
what about
their
their
palate.
voice? Do some of your patients lose their voice
Sure,
entirely?
certainly they do when it's because of the voice box coming out. Then we do that kind of reconstruction, but it's not very fancy, so to speak. But back to the plastic and reconstructive surgeons, they will put up large pieces of tissue. They will develop very refined, very function-specific reconstructions to help out the tongue, to help out the jawbone, to create cosmetic repairs that
and just
really
to give someone a better quality of life.
That's correct.
For the rest of their life.
Like the breast surgeons, and those two are reconstructive surgeons. But in the head and neck area, it takes a real special talent to do it.
Absolutely. Well, we've run out of time. Dr. Spring, this was an awesome topic, very informative. We thank you so much for being here, and I hope everyone really enjoyed the show. For those of you who want to contact Dr. Spring's office, you can call 504-889-5335, or you can visit MeteryENT.com. I'm Maria Muro, and I want to thank you for tuning in to Doctors New Orleans. Remember, if it's about health, we cover it, and we want to hear from you. Thank you for your calls tonight. We hope you found the show informative, educational, and inspirational. Stay healthy and good night.
Doctors New Orleans is underwritten by Acadian Ambulance Service and New Orleans Living Magazine.
What if there was a hospital that treated childhood diseases while still allowing kids to have a childhood? It would require thinking on a smaller scale in order to lead to bigger possibilities. It would require doctors and nurses with imaginations as big as those they treat. It would require putting children's lives before all else. It would require a hospital whose singular focus is children. That's Children's Hospital New Orleans, caring for every child as our own.